Hi everybody, this is my presentation on cystitis this week. The client setting a background, we're at the PCP office, a 26-year-old. She's a female and Caucasian. She is single. She's employed as an accountant and she is insured. Her history of present illness is she's complaining of lower abdominal pain and increased urinary frequency. Quality is not applicable. The severity is moderate. It's affecting her ADLs. Associated signs and symptoms, there's none at this time. The timing is 12 hours after intercourse. It occurs after intercourse. The duration, symptoms have been occurring for 5 days, and there is no modifying factors listed. Her allergies are to ciprofloxacin with no known food allergies. She does take a woman's multivitamin, omega-3, and low loestrin, which is a combined oral contraceptive pill, every morning. Her chronic medical conditions include PCOS and chronic frequent urinary tract infections. Well, she's had 4 over the past calendar year. She's had no surgeries. Her review of systems is overall generally benign with the exception of her for GU. She is endorsing increased urinary frequency, and then GI, she's endorsing lower abdominal pressure. Everything else, though, is within normal limits. Her reproductive history includes birth control. Method is the COC pill. Her last menstrual period was 11/17. She menstruates for 3 days at a time, and her cycle is fairly regular. She is G0. She is sexually active with her boyfriend of 3 years. Additional subjective questions I would definitely ask this patient is if she had any new sexual partners recently, as this can introduce new microflora and biome into the vagina and then thus cause a urinary tract infection. Has she been experiencing any abnormal vaginal discharge? This will just help me rule out if this is a sexually transmitted disease, and these are the signs and symptoms associated with that, or is this really and truly a recurrent urinary tract infection? Has the patient used any new products on her vagina? Sometimes when we use new products within washing ourselves, it can cause dysuria and upset the microflora. So I would definitely want to know that. I also would want to know if she's been utilizing spermicide with her partner, as this can be definitely detrimental to the microflora as well and very irritating to the vagina. Does she urinate after sex? It's really important that the woman after intercourse is urinating, as this can get rid of the bacteria that is just sitting there after intercourse. And has she been experiencing any diarrhea? This is really important just because then I can understand if she is having diarrhea, maybe the bacteria is being introduced from the gastrointestinal tract. These are her vital signs, nothing out of the ordinary. I would definitely pay most attention to her heart rate and temperature at this time because I would be concerned for pyelonephritis. Has this gone up so far to her kidneys? At this very juncture, it doesn't seem to be that serious. It seems to be cystitis. Her physical assessment is listed below. Her heart sounds S1 and S2 are heard on auscultation, normal rate and rhythm, lungs are clear. Her uterus is normal in size. There's no cervical motion tenderness. She has no lesions to her vulva. She has no cystocele, retrocele, and she has good pelvic muscles and tone with palpation. No discharge, lesions, or redness. Skin is dry without lesions. GI, she doesn't have any hemorrhoids. Her abdomen is soft, but she is endorsing some pain to the lower abdomen with palpation. She does have active bowel sounds. Hint, everything is within normal limits, as well as neurologically, she is completely intact. Laboratory testing that I would want to do immediately is a dipstick analysis in office. That's quick, that's easy, that can give us a really good indication if we see leukocytes or blood present in her urine, as well as protein and nitrates, which can be a big indication of a urinary tract infection, as well as bacteria and white blood cell counts. I would send it to be cultured regardless if the dipstick analysis wasn't as indicative of infection, just because I feel like that's more conclusive. We have the reference ranges here, and we have her urine analysis from 10 months ago, but we really don't have a current one on file. So I would want the dipstick done in office, a urine culture to be sent to the lab. And I would want a complete metabolic panel. I want to know her electrolytes, if she has any nutritional deficiencies, and I really want to know her kidney and liver function. If we're going to be pursuing antibiotics, I want to make sure that both are within normal limits, and because some of these antibiotics can be particularly harsh on the kidneys. Antibiotics listed here are of the sensitivities that are shown, and it seems all of these are sensitive to the strain of E. coli that has been seen in the culture. Immediately, we have to get rid of this her allergy. She can't have, I believe it was the ciprofloxacin. So she can't have that, so we cannot give her that. So that is immediately out of the running for an option for an antibiotic. I would not pursue any diagnostic imaging at this time. It could be a good idea to get an ultrasound just to see if there's some kind of physiological issue. I just wouldn't pursue it at this time. I would probably try to go with the antibiotic route, see if that's effective, and then if that isn't, then go from there. She does have a recurrent urinary tract infection. That is the diagnosis. The plan of care, if we're going with the nitrofurantoin or macrobid, it is very strong, and it is advocated to be used with cystitis. She is going to be prescribed 100 milligrams BID times 7 days. She's to be dispensed 14 pills with no refills. This would be the antibiotic of choice for me because it has tolerable side effects, and I think that's really important when giving an antibiotic or introducing a new medication to a patient. It is also well known to eradicate E. coli. I would have her follow up with me, and then I would consider long-term antibiotic regimen if it could be indicated that she needs to be on it for 6 months, low dose of nitrofurantoin. But I would really just hope to go with this plan of care first, in hopes that it does clear her urinary tract infection. And then non-pharmacologically speaking, she should be on probiotics, specifically lactobacillus, because it creates a vaginal barrier to pathogenic bacteria. And then D-mannose has been really interesting as of late, because it's been proposed that it can aid in recurrent cystitis due to its ability to bind to the bacterial surface ligands, which decrease the adherence of the infecting organism to the mucosa. So these are definitely non-pharmacological options that I would advise for her. At this time, I would say skip the cranberry juice. I know it's been kind of a popular in terms of taking care of a urinary tract infection. However, the Cochrane review showed there's no significant reduction in the incidence of UTIs in subgroups who take cranberry products. I would have her urinate immediately after sex. Avoid using spermicidal lubrication. She needs to have proper perineal care and wiping front to back. She should increase her fluid intake, as it's going to make her urinate more and get rid of unwanted bacteria. She should wash her hands before and after wiping, as to not introduce new bacteria, and she should avoid wearing tight-fitting clothes. These are my references. Thank you so much.